Hi Mark. I have a very strong manual therapy background. Do you think the kinetic control process fits into this process as well?
Yeah, Jacqueline, I think the kinetic control process in particular builds on the manual therapy background that I started with as well. My manual therapy background was very much joint pain orientated. And now I think the kinetic control process has moved further than that, and I think manual therapy in generally has moved a lot further than that as well. So rather than treating joint pain, which was the simple message I got when I trained, we're now looking at movement, and we're now looking at movement in terms of symptoms in the movement system, impairments in the movement system in terms of joints, muscles, neurodynamic neural tissues and neurodynamics, and also connective tissue and other structures. So we've got a lot of ways of testing for impairments. We also look for disabilities or limitations of activity. We also look now at recurrence, which hasn't well been addressed in the past. So those four key elements are what manual therapy is all about nowadays. And rather than just the joint, or doing a joint assessment, tagging on all the others, I think we're now doing movement assessments. And as far as the impairments are concerned, we're looking at two sides. So the uncontrolled movement is the new theme. It's become a big theme, and so we're now looking at structured and specific ways to test for uncontrolled movement in terms of uncontrolled translatory motion or uncontrolled range of motion, with lots of strategies to deal with that. But it's not just dealing with the uncontrolled movement, which I see manual therapy has sometimes sort of gone to and forgotten its roots. Its roots is mobilising restrictions. But restrictions cause compensations, and they're just two sides of the same coin. So manual therapy nowadays is really about looking for restrictions and compensations, managing the compensations better, dealing with the symptoms, and if the symptoms are neurogenic pain, we've got strategies to deal with that now, rather than just being all simple, nociceptive, inflammatory, peripherally mediated pain. We're looking at a lot more different pain mechanisms in terms of the symptoms. We're more structured in looking at impairments. We take into account disability. We have tests that try to measure disability and functional and how people's function changes because of their pain or their other symptoms, and we're also managing recurrence more effectively.
Okay, great. So it sounds like you're looking more for the cause of the problem now, and not just going down the route of symptoms. So
yeah,
you're having an influence on more things.
I think that's one of the big things, is that when I was brought up in the traditional manual therapy background I was brought up in, it was very much treat the symptoms.
Yeah.
And and if we think of that TV show CSI, it's a good analogy. It starts off with a corpse. So treating the symptoms in terms of musculoskeletal pain is burying the corpse, and that show would be nothing if we finish in 5 minutes. So it's all about the forensic detective work, and what I think we should, as therapists and manual therapists, should be nowadays, we should be doing the forensic detective work on the movement system to find the cause of musculoskeletal pain and impairments, not just treating the symptoms.
Okay, great. I know you have a particular interest in restrictions influencing uncontrolled movement. Could you discuss how this fits into the manual therapy?
It's two ways. Is that one of the things that we recognise is that restrictions cause compensations, and what we in particular are looking for is those compensations and how better to control them. What is the relationship between restrictions, compensations, and pain? One of the things that I've become more and more convinced of over time is that when people have pain in function, they don't get the pain where the restriction is. They get the pain where they compensate for that. So, for example, if someone's got a stiff upper lumbar spine, when they extend and it doesn't extend adequately, when they extend, they don't hurt where they're stiff. They hurt at the L5S junction where they hinge and compensate for that. When people have a shoulder that lacks medial rotation, they compensate with forward glide of the humeral head. It's not the posterior shoulder where the myofascial restriction is, it's the anterior shoulder where the capsular strain is. So I see that restrictions don't cause pain in function unless there's sensitization. That sensitization can be biochemical, so in an acute episode there's inflammatory chemicals, and so restrictions hurt in the presence of an inflammatory episode. Restrictions also hurt in the presence of neurogenic pain. But if people don't have that, if they've got what the majority of our patients are, they're out of the inflammatory episode, they may not have a dominant neurogenic mechanism, there might be a bit of neurogenic starting to sneak into the background, but they've got mechanical pain, mechanical movement-based pain. And then going down the path of finding the restrictions that cause the compensations. So it's easy to find where they compensate. Ask them where they hurt. And we can do then tests of demonstrating that there is uncontrolled movement where they hurt. What our trick is and the way that we can best use our manual therapy background into the new skills of managing uncontrolled movement is to try and start to reverse engineer the process. If I've got this uncontrolled movement as a compensation for restrictions, where are the possible compensations? The neck's a very good example. It's very common to get mid-cervical pain associated with hinging in the neck. So we can find the C3-4 as a segmental hinging area, so it has uncontrolled extension, uncontrolled translation. Okay, what are the restrictions that might contribute to that? Well, maybe a lack of, we've got increased anterior glide at C3-4, so lack of posterior glide at C3-4. We can palpate and mobilise that. We can also have a lack of extension at C5, 6, 6, 7. And there's research, Kevin Singer's research showed that very clearly, that you compensate it higher up for that particular restriction. So we have to mobilise that restriction. We can also have short anterior scalings that hold C4, 5, 6 and 7 forward. And if you don't extend, if the myofascial restriction at the front of the neck limits extension in the lower neck, you hinge off the C3-4 above it. So that's very simply a case of 3 different restrictions linked to that one side of pain. And how often do we as clinicians routinely go looking for those, let alone the other myriad ones? There's more than that, but they're 3 top of the list that are very common. And so for those of us who are treating mid-cervical pain linked to extension, if we leave those restrictions behind, even if we're symptom-free, our functional activity is going to start to compensate above those restrictions again. So it's not surprising that the pain comes back. So we don't manage recurrence. So if we do a better job of finding the integrated list of restrictions, that there are many restrictions that can cause any one particular pain-related uncontrolled movement. If we understand those links and then go looking for them, we can clear a lot more of them out and help influence recurrence better.
Have you seen that when you actually try and, or you just go down the route of fixing the restrictions, that your pain actually increases?
Occasionally. There's 2 problems with just doing that. And if I use a couple of examples, one is that if you've got short hamstrings and the lumbar spine overflexes as compensation, then we could maybe argue that if I get better hamstring length, my back doesn't have to flex as much. But the brain doesn't work that out. The brain just realises it can now put its the hands flat on the floor rather than your fingertips to the floor. So you still use the excessive flexion you've developed, even though your hamstrings can move now. Sometimes it's also the problem that the myofascial restriction is sometimes the last thing holding you together.
Oh yeah, so that would increase your symptoms.
So sometimes you take away the last thing holding you together and then you fall apart. So last man standing is not the man to remove.
Yeah. I've always enjoyed watching you reason through a clinical case study. What factors do you think are important in the clinical reasoning process?
Clinical reasoning is very difficult to teach, from a theoretical construct. There's some nice books on it by Mark Jones and other people, but the best way to teach it is to show it in action. And the way to do that is to explain your thought processes and try and verbalise the thought process of, I've seen this, therefore that could mean this or this, then where am I going to go? But the end result of a good clinical reasoning process in manual therapy and in movement therapies, and particularly for pain-related problems, we should try and come up with an understanding of things. If we've done the detective forensic work correctly or efficiently, we will have information about 3 things. We'll have information about the uncontrolled movement in terms of the site and direction. So the site, glenohumeral direction translation, or site scapular forward tilt, or mid-cervical C3-4 extension hinge with rotation. So we can identify the site and direction of uncontrolled movement because that tells us what we've got to fix. And it gives us a head start on strategies to fix it. We also need a diagnosis of understanding where the pain's coming from. We still have to treat the symptoms. And so a better understanding of, and particularly when we get non-specific back pain, non-specific neck pain, non-specific shoulder pain, the real reason for getting that diagnosis is there's more than one tissue responsible for the symptoms. That's why it gets the label non-specific sometimes. There's no one tissue that can explain, no one bit of pathology that can explain all the symptoms. And what we have to accept is that in most people with chronic and recurrent pain, there's more than one tissue contributing to the pain mechanism, and then we need to optimise their physiology and pathological processes so we can heal better and decrease the symptoms. And then we still also need to have a process of identifying where the what pain mechanisms are involved. Is it a peripheral peripherally mediated, nociceptive, biomechanical, inflammatory pain mechanism? Is there a peripheral neurogenic? Is there a central neurogenic mechanisms? And the relative proportions of those by the time someone's chronic. One of the ways to think of those tissues and just a strategy to think about is that it's common, and a lot of clinicians out there will recognise instantly, a patient will come along and say, I'm not too sure there's much you can help me with, I've seen so-and-so and they told me my back pain is due to a disc, or I've seen so-and-so, I've seen someone else and they said it's the joint, someone else said it's the nerve, and someone else said it's the ligaments, and they get disillusioned with having multiple tissues. And what they've got is good diagnosis. Someone has told them the combined myriad of their pain-sensitive tissues. The trouble is when we go down the path of just trying to treat the tissue as the pain source, we sometimes focus on that bit and not why it's sore. And so if we go down the path of a movement control model, and patients who said, well, when so-and-so treated this, they flared it up or whatever. If we go down the path of saying, I don't want to do that anymore, what I want to look at is, what I want to try and identify is, what do you do wrong? What are the key things that you do wrong? And what movement faults do you have that stress all of those tissues? And then how about, rather than just bang away at the different tissues, how about we actually try to change the way you move? Change the way the brain works in how it coordinates your movement. So if we can change the way we move, or if we stop you moving in this aberrant pattern that puts stress on all these tissues, the stress goes away. The body, given half a chance, will start to look after itself.
Oh, well, great. That sounds brilliant. Okay, well, being a South African, I need to pretty much ask you, we've got a very strong background in rugby and cricket, and I treat a lot of athletes as well. Do you think the performance matrix can help the sports person?
Rugby and cricket are two good examples of different sports. Cricket's an endurance event. Test match, like 5 days to one game, But so people involved in bowling and cricket, get lots of overuse, stress-related injuries. And rugby's an high intensity, high power, explosive force game. So it's high. So rugby's high impact. But the bottom line is there's a tipping point between tissue stress and tissue tolerance. And going from training tissue stress in a controlled way, so we build tissue strength and build tissue tolerance, or overloading tissues, and so we get into tissue distress, and then we fail. Tissue tolerance fails, and we go down the path of pain and pathology. And that's where I think something like the matrix has a real benefit. It's like the quality of manual and physiotherapy in Australia and in New Zealand and in South Africa and in most of the Western world is very high. So everyone's good at treating the symptoms. We're good at treating the symptoms. We can hide the symptoms with drugs, there's lots of ways we can change the symptoms, but stopping them from coming back, or taking the risk away from known risk factors, so cricket fast bowlers and their back and interarticular powers and reticularis issues, for example. They're high risk factors, they're known risk factors. And if someone has uncontrolled movement, when they are pain-free, full strength, full range of movement, but conditioning themselves to high intensities of training, then picking uncontrolled movements in people who are at the tipping point can mean all the difference between them failing and improving.
Okay, we always say prevention is better than cure, and there's a lot of injury prevention programs available out there. What makes Performance Matrix different from all the others?
So there's lots of things that have shown to have some efficacy or use in injury prevention, and what we know is bottom of the list: general strengthening and flexibility. And there's good RCTs now that show that, maybe a particular muscle strength or a particular issue for a particular sport for a particular injury, like ACL injuries in female netballers and basketballers, and the knee single leg landing and the knee coming in. But that's not a risk factor for male. So there's an individual test that's thing for one thing. Certain strengths are relevant for certain injuries, but not across the board. So general strengthening and flexibility doesn't prevent injuries or predict them. They're definitely good for performance. But so the message is what's going to have an effect on injury prediction and prevention. There's things out there nowadays that have come in the last 10 years as neuromuscular retraining. So there's lots of neuromuscular retraining programs out there, and they've been shown to have positive benefits for injury prevention. So the two things that, in terms of sort of exercise-based stuff that's generally done, are general neuromuscular training programs, which look at balance, agility, coordination sort of stuff, and some of them are made sport-specific using sport-specific skills, but they're still the same thing, the neuromuscular retraining and general aerobic fitness. They've been shown to have benefits for injury prevention, but not prediction. Okay, and I think one of the things where what we've got an issue, where we've got some advantages with now, is looking at uncontrolled movement as an element for all of that. Uncontrolled movements find the restrictions. When you've got uncontrolled movements, you can go and find the restrictions that are relevant for compensation, because not all restrictions cause problems.
Yeah.
We can find uncontrolled movements that don't need strength; they just need alignment coordination. So strength, looking for uncontrolled movement can answer some of the deficiencies in why strength training has been shown not to be predictive or preventative, and general flexibility work has been shown not to be predictive or preventative, because the missing link in the middle of that equation is what's uncontrolled and what's not. Then also I think we can find that the uncontrolled movement side of it is a little bit more predictive. There's been some research in particular from people like Natalie Russell who's shown that tests of movement control or uncontrolled movement tests can predict injuries in dancers. So there's a starting area here that's very new, and I think that's one of the things that the performance matrix really brings to the system is we can find uncontrolled movements that are fixable, and so the idea of that is that and they're also, we find them in multi-joint chains. So we don't look at one joint at a time and just do a whole bunch of tests there. We look for, in a chain of joints, is there other uncontrolled movements, because they're the ones that are going to affect functional movements across a chain of joints as well. And so by doing something about that, I think it's a new area, and I think it's going to make a difference, and that's unique. And then identifying that in terms of the site and the direction of uncontrolled movement, and then in terms of the threshold, alignment coordination, or whether it's strength speed, gives the person who's got the job of fixing it an easy time. Because we can do 40 minutes of general neuromuscular training or conditioning or aerobic work, or we can do 15 minutes of targeted focus retraining for a particular risk factor in a particular athlete. That gives them time then to focus on other things.
Okay, that sounds very interesting, Mark. Now, just out of, I treat a lot of sports people. Who needs this screening? So do I screen all of the players? Because it sounds like I need to.
If everyone had access to it, they'd be crazy not to take it up.
Oh, great, yes. So we screen everyone.
Because basically, it's information. And what do triathletes spend? They will search the internet for hours for information about a bike that might make a little bit of difference.
Yeah.
And then they'll spend 7,000 euros on it or something like that, or so there's people out there who spend a lot of time, and then time is valuable for them, and training time is valuable, and then also identifying risk factors that might then, you've got to ease up on this, but you can push this if we've got assets and risk factors. So in terms of they can better plan the training program, so there's assets they can find that they can push because their tissues will tolerate it better, and there's things they want to hold back intermittently until they fix those problems, and then they can push them again as well. But I think given the opportunity, if everyone could do it, they would see the benefit. It's just that without them understanding it, and I think that's part of the problem, is if people understood that the body's something that isn't as tough as you think it is.
Okay, well, thank you very much, Mark. So it sounds like if we can keep the sports people injury-free, that could lead to their performance enhancements, and hopefully we see more results then on your program. Thank you very much.
Okay, thanks, Jacqueline.
Thank you.